Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned Padma Shri Dr. Kamini A. Rao. Ma'am is a chairperson of the International Institute of Training and Research in Reproductive Health, founder and medical director of Milan Fertility and Birthing Hospital, Bangalore, founder and chairperson of Medline Academics. With the help of Ma'am and her wonderful insight, we will be taking a close look on today's topic, which is ovulation induction in art. Now, without any further delay, I would like to welcome Ma'am at our forum and would like to hand over the session to her. Over to you, Ma'am.
Yeah. So, thank you all very much. I'm sorry I have been a little late, but we won't take any further delay and we will carry on. Can you see my slide? Can you see my slide? Hello? Can you see my slide?
Yes, ma'am. It is visible, ma'am. It is visible.
It's visible? Okay. We're just going to be talking on what would be the changing trends in ovulation induction, because all of us have done some amount of ovulation induction, but let's see what has been the current trends in the ovulation induction. So we will have to divide it into three parts. One is, are we going to do it only for timed intercourse or for IUI, and of course for the IVF? And if you have to see that in vivo conception, I'm sorry, that is when you're looking at the ovulation induction for timed intercourse and for IUI, and the other one is, of course, for the in vitro conception. So it is going to be different only because we are looking for singleton pregnancy, where we are looking for ovulation within the body. And the other one, of course, for the IVF, we're taking the eggs out of the body. So even if there is multiple ovulation, so we're not really worried because the eggs are outside the body and we wouldn't worry too much about the hyperstimulation. So before starting ovarian stimulation, we need to understand a little bit more on the ovarian reserve. Now, when we look at the ovarian reserve, we have to understand the primordial pool. So, the proof of the primordial pool will be, of course, these follicles. Then we have the committed follicles, will you find over here. And then you come up to this point where you see the antrum forms and the antral follicles. These are the these are the gonadotrophic responsible sensitive follicles. Here you'll see the ones with the red on it. Okay, and then of course you go to the slightly larger ones, and that would be the follicles that are the gonadotrophin dependent follicles. Then you have the bigger ones that become the ovulatory follicles, and then the ovulation. So what happens to the other follicles? The other follicles, of course, goes through atresia. So how do you analyze the ovarian reserve? You analyze the ovarian reserve by the pool of follicles, not the primordial pool, but the antral and the preantral follicles. Now, in a single ovulation, what do we see? There's a small threshold, the FSH threshold. So within that threshold, you're able to get one dominant follicle reaching ovulation. So as soon as this threshold closes, there is one follicle that is grown much bigger than the others. So a cycle of dominance, the rest of the follicles go through atresia, and this goes through ovulation. So as the FSH rises, the follicle grows, and as the FSH comes down, the LH takes over and the ovulation occurs. So the rest of the follicles go through atresia. But look at this, the same FSH window now has enlarged. So when you go through ovarian stimulation, this is the enlargement of the FSH window, thereby the threshold enlarges. So unlike in this concept, here we are enlarging the FSH window, and so multiple follicles develop, and therefore you get more than 3 coming up, whereas you got only 1 there, and therefore that is the whole purpose of stimulation. So to define goals of ovarian stimulation, you enlarge the FSH window, though of course you do have atresia also occurring, but there are a large number of follicles that will reach maturity. Okay, so if you looked at all the others, this will be the biochemical parameters which will select the correct pool for the stimulation. All right. Now, if you were to look at again this particular area, now we have to look at the ultrasound picture as well. Okay. So once ovulation induction is initiated on day 2 or 3, because selection of dominant follicle occurs in the early follicular phase, it should be initiated only when the follicular size is about 10 millimeters in the absence of any ovarian cyst, and the endometrial thickness is about 6 millimeters. So when you see this, this is a cyst appearance on second or third day. And of course, you must also see that you'll see here the length and breadth of the uterus. This is how you measure. This is the longitudinal section. Okay, and you'll see these small follicles in the ovary on the left and right side. Okay. Now, what would be the drugs used for ovulation induction, stimulation? Now, look at the hypothalamus-pituitary ovarian axis. You have the neurokinase, the KISS peptide, the hypothalamus, and the GnRH agonists. These are the GnRH releasing factors that come from the hypothalamus and directly acting on the pituitary. Now, GnRH agonist and antagonist, and all of them come at the pituitary level. Other insulin sensitizers, androgen, growth hormones, adjuvants, and all come at that level. From the pituitary, you have all the activins as well, locally also acting. Then from the pituitary, you have the FSH, the LH, you also have the steroids, inhibin, activin also having the short loop and then acting on the ovary. In the ovary itself, you will have not only the estrogen progesterone acting on the ovary, you also have a loop mechanism where you will see the inhibin and the activin also acting. Okay, so you have all this loop kind of picture here, which means that you will have the hypothalamus with the releasing hormones, the pituitary with the stimulating hormones, and then you have the estrogen and progesterone. And that is the entire hypothalamus-pituitary ovarian axis. Now, when you choose the correct dose for the stimulation, it should not be hypo or hyper response. So to establish the optimal response, one has to be somewhere in the middle. And so what would be the middle response? One has to understand that you have to have, if you have a poor response, then you have less than 4 oocytes. Okay. And if you have a disturbed, risky benefit response, you would have excessive of 15 oocytes. And a normal response in the green would be anywhere between 5 to 14 oocytes. So if you see, if it is less than 4 oocytes, it's indicative of one, a low ovarian reserve, which gives low pregnancy rates, and or the need for higher dosage of FSH. All right. Otherwise, we need to go here. And if you've got 8 to 15 oocytes in this place, you either have accompanied increasing numbers of immature oocytes and therefore be careful of ovarian hyperstimulation syndrome. So, excessive of more than 15 oocytes, you could be in a little bit of a trouble with excess oocytes. So, most of our ovulation protocols using gonadotropin should be efficacious and safe. It prevents follicular phase, that is, progesterone rise, prevent poor and hyper response, and results in pregnancy. It should be low risk of multiple pregnancies, decrease imprinting disorders and epigenetic abnormalities, and gives you a better neonatal outcome. So that is how our protocols should be. It should be efficacious and it should be safe. So what does the recent literature tell us for women going through ovarian stimulation? The new protocols for the stimulation is for LH suppression. So using progestins, late initiation of stimulation using long-acting GnRH antagonist. Okay. There is one controlled ovarian hyperstimulation, and these are individualized protocols, modified natural protocols, mild stimulation, addition of LH activity, long-acting gonadotrophins, and random start protocols so that you prevent OHSS and you can give a dual trigger. Like you can give an agonist trigger and you can give an agonist plus an HCG trigger. The second thing here is pre-existing ovulation induction protocols are the ones where you do a down regulation with an agonist. That can be a long down regulation protocol or a short down regulation, and then you have an antagonist protocol. The other one is the conventional stimulation, low dose, chronic low dose, step down, and sequential. There you can give a HCG trigger or an agonist trigger. The other one is, of course, pre-treatment. You give pre-treatment with estrogens, progesterone, or OCPs and antagonists. So all these preparations are used in select cases. Okay. Now, when you pre-treat with GnRH agonists, why is it required for? It's required for synchronization of follicular development, prevention of occurrence of large follicles, early large follicles, and prevention of spontaneous LH surge, reduction of cyst formation, and scheduling of IVF cycles. So this actually sums up why do we take this kind of stimulation is basically to our comfort and to discipline the ovary to grow in a kind of manner which gets all the follicles in a kind of uniform growth pattern. And that's how we will see how it goes. Suppose you are going to give them estrogen valerate. Okay. How do you do this? One, estrogen valerate can be given in the dose of 4 milligrams for 6 to 10 days prior to stimulation. Or you can also give progesterone primed cycles, that is norethisterone, 10 milligrams daily, or medroxyprogesterone acetate, 10 milligrams from day 16 to day 25. Then you can give a combined oral contraceptive pill from the cycle day 1 to 5 for 21 days. Not recommended as they reduce the efficacy of controlled ovarian stimulation in antagonist cycles. However, GnRH antagonist from menstrual cycle day 2 for 5 days before the start of gonadotropin therapy with or without estrogen priming of 4 milligrams, beginning for a week, following their previous ovulation until menses. Now, these drugs used for pre-treatment, like estrogen, progesterone, combined oral contraceptive pills, GnRH antagonist, or before ovarian stimulation, using the GnRH antagonist protocol is probably not recommended for improving efficacy and safety. No increased live birth rates, and a good option for scheduling cycles and synchronization of follicular development so that you don't have any pickups on Saturdays and Sundays. Now, if you look at the agonist, all right, you have a standard regime that you start the agonist on cycle day 21, and then you start the recombinant FSH of 150 international units at this point, and you continue it every day, all right? So from menstrual day, you start day 1, 2, 3, 4, and then you go up to day 9, all right? So when you reach day 10, you start, do the scans as well. Now, in a short protocol, from menstrual day, okay, you give the agonist day 2 to day 4 to get the short burst, the flare of the agonist. Then you can give the gonadotropin of 37.5 to even up to 150 international units, and you can continue the treatment. But the agonist is given only for 2 to 4 days. That is day 2, day 3, and day 4. All right. And the standard will be in the antagonist cycle. That's fixed and flexible protocol. Okay. The antagonist can be given on day 6, 7, 8, 9, and then, of course, 10 plus minus. Okay. And in this, of course, you are giving it as a standard regime. You can start from day 6 and you can go up to day 10. Okay. So if you're giving fixed and this thing, sometimes the flexible protocol will be much better. Now, the other ones are when you give the progestins. Now, in these progestin primed cycles, you can't do the transfer on these cases. All right. So you're giving the progestins, all right, and the embryo, okay, vitrification or oocyte vitrification. All right. So though this thing, you don't transfer in that cycle. Is that clear? And what happens here is in these cases, the new protocols for suppression. So what happens is, though they do not allow for transfer in the same cycle, you will not, it's a poor man's way of preventing LH surge, and you keep giving the progestin so that the LH does not come up, but that LH has not got any effect on the oocyte. All right. These are the HMG, gonadotropin releasing hormones, and of course the oocyte retrieval, and the same with here. Now look at this. Okay. We are giving the long agonist protocol. So it starts from the previous cycle. Okay. Previous cycle, 1 week before. And use of long acting GnRH antagonist protocol also is there, but not used as much as the long agonist protocol. So beyond GnRH antagonist protocol, the progestin suppression for LH, the ovarian estradiol is responsible for the LH surge, and progestin can block the estradiol induced positive feedback, and therefore high plasma concentrations of progestin enhances the negative feedback effects of progestin, of high plasma concentration of progestin enhances the negative feedback of estradiol with suppressed FSH and LH secretion. So it's important for us to understand that that is the way the oral progestins help to prevent the LH surge. So it reduces the cost of treatment by giving agonist, and this progestin is administered in the form of just 10 milligrams a day from day 2 to 3 till the day of agonist trigger. So it maintains the pituitary suppression and prevents the LH surge effectively, with comparable oocyte yield and pregnancy outcomes as GnRH analogs, but is feasible only if fresh embryo transfer is not scheduled. That's important. Embryo transfer is done in subsequent natural or HRT cycle, and as the endometrium would not be receptive in a fresh cycle due to the effect of the progestins. So it's easy, cheap, and patient-friendly approach. However, the evidence is limited. So if you look at the studies of use of progestins for LH suppression, you will find that there's not much difference in either the GnRH antagonist or the progestins. So both have been successful in their own way. So when you did the non-inferiority study, there has not been much difference, and MPA is not inferior to ganirelix. So initiation of controlled ovarian stimulation in the late follicular phase using FSH alone without exogenous pituitary modulators for LH suppression, and late follicular phase presence of one dominant follicle and several subordinate follicles which are less than 10 millimeters before the ovulation of the initial dominant follicle. Then after ovulation, endogenous progesterone produced by the corpus luteum is sufficient to prevent the occurrence of secondary premature LH surge induced by the pre-ovulatory follicles growing from the initial subordinate follicles. So spontaneous LH surge of the initial dominant follicle does not exert any influence on the subordinate follicles because LH receptors of the granulosa cells are less expressed in ovarian follicles which have a diameter of less than 10 millimeters. So the recommendation has been the use of progestin for LH peak suppression is probably not recommended, and if applied, progestin can only be used in the context of non-transfer cycles. So you can't use progestin in transfer cycles. So medroxyprogesterone acetate versus ganirelix in oocyte donation cycles has shown that the p-value here and clinical pregnancy value, you have a better value with ganirelix, where the p-value is 0.006 and significant. Okay, so late follicular phase stimulation, you'll see with a retrospective study of 135 patients, we find that the late stimulation protocol, the HMG gonadotrophin used the starting day on menstrual cycle day 8 to 21 with a dominant follicle diameter of more than 14 mm before ovulation and triggered with HCG, the oocyte retrieval done. And whereas when you take a short GnRH agonist protocol group, and there you give HMG and a releasing hormone agonist. So here what happens is you have given a HCG in the top line, and in the bottom line, you're giving an agonist and the oocyte retrieval. Here you're again giving, it's triggered by HCG for oocyte retrieval. So if you looked at the late follicular phase initiation, you'll find that the clinical pregnancy rates is 61% versus 52%, hence not significant. So whether it's antagonist protocol or the agonist protocol, there's not much of difference that we can see. So the long agonist protocol, endocrinological variation during ovarian stimulation. So therefore, single luteal use of long-acting GnRH antagonist is effective in down-regulation of pituitary during ovarian stimulation. Okay, the long-acting antagonist protocol. Now, if you have the long antagonist protocol, and this is a study in infertile women, so it's a classic fixed day 6 GnRH antagonist protocol, and that is 0.25 milligrams of ganirelix on day 6. And group B is the long antagonist group, 54 patients, where the long antagonist protocol and a bolus injection of 0.5 ml of decagarelix on day 24. So the only cumulative ongoing pregnancy delivery rate of 55.5%, which is, of course, a statistically significant of p-value of 0.05, is significant in this group of long antagonist protocol. Okay, so when you see this, okay, individualized, so the advances in controlled ovarian stimulation that have improved in the outcome of ovulation, this thing is individualized controlled ovarian stimulation, natural and modified natural cycle, and mild stimulation. So if you say use of a long-acting FSH or a double stimulation and random start protocols for taking up for mild stimulation, these are all for fertility preservation. You can use this, and these are something which makes the ovary a very, very safe subject, that it can convert a follicular phase into a luteal phase into a follicular phase, because the follicles are so dynamic, they can start at any time to grow, even if it's in the luteal phase. Okay. So here also, if you look at the step down protocol, the step up protocol, all these protocols will show you that where it is a step up protocol, you can use the clomiphene citrate or the letrozole and the tamoxifen. So if you're using letrozole, you're using 22.5 milligrams, tamoxifen is 20 milligrams, and clomiphene citrate is 100 milligrams. So whilst you're on the oral ovulogens up to day 6, and then you can start your gonadotrophins, which is in the range of either 37.5 international units to 75 international units. So the step up would mean that you start from 37.5 and you can go up to, say, 150 international units, and giving it enough time for it to grow, sometimes 5 to even 7 days. That will be the step up. The step down would be to start the same thing, but you can start at about 100 or even 300 international units, and then bring it down to 150 to 150 international units, and you slowly bring it down to 150 or even 75 international units. So 5 days, 10 days, and 15 days. So 5 days, you give it, scan, and then bring down the dosages. The other down regulation is the starting dose of 100 to 225, and then decrease it by a bolus of 37 to 50 international units. And when the follicle is about 9 millimeters or 10 millimeters, you start decreasing it, so that once they are recruited, you're hoping that the amount of gonadotrophins required by them to grow will be much less. Now, the low dose protocol. The low dose protocol would be, you start the dose by giving in the non-ART, you will be giving them 37.5 to 75, and in an ART, you give them 100 to 150, you increase it by 50%, but you scan on day 7. And then the HCG of 5,000 units. The dominant follicle will be about 17 to 18 millimeters. Now, the other thing would be to start by 100 to 150 here, and you can increase it, okay? You can increase it again to the same thing of instead of 50%, you can increase it by 100%. Okay. And the other chronic low dose is non-ART 37.5. Then again, you increase it on day 14, increase it by 50%. And then if it doesn't really show up, particularly in these PCOS cases, you can increase it by 100%. These kind of permutations and combination is called personalized medicine for ovulation induction. Now, based on the ovulation response to treatment, AMH and AFC and other factors minimizes the risk of cancellation of cycles and OHSS, poor response, and multiple pregnancies. So helps to increase the success of ART and decrease stress, anxiety, cost, and complications. Okay. So response is also influenced by patient characteristics like age, all right, and then also the BMI, the ethnicity. In fact, Caucasian women have a faster development of the follicles when compared to the Indian women. And then addictions to alcohol, smoking, and drugs make an altered response. Then also depending on the causes for infertility and genetic factors like FSH and LH polymorphism, then also the past performance of response to drugs and risk tolerance to the drugs as well. So, individualized FSH dosing based on ovarian reserve testing in women, starting IVF and ICSI. And this has been a multicentric trial and cost-effective analysis. So, individualized versus standard IVF dosing in women starting in IVF, it's an RCT and the predicted poor response. So, one has to understand that whatever you may do, and with all the information that you have, you can still have a googly and a person may not respond. So, you have to individualize that person and you have to be prepared for any mid-course corrections that you may have to do with that person. Okay? Just 1 minute. Yeah. So the for this is the one. So one other thing is we have this with the LH supplementation, we have to see in the yeah. After this, of course, we go to the next one. Individualized protocols based on the ORT did not improve the live birth rate or reduce the cost, but it does increase the safety and effectiveness. So natural and modified natural cycles, HCG only, antagonist and FSH HMG add back, and the aim here is to obtain a single oocyte. But the pregnancy results are low. So when you take a minimum stimulation cycle, the ideal number of follicles desired will be anywhere between 2 to 7, and it will be appropriate for younger patients, good responders, and the PCO patients. Here, the advantage would be a reduce in the gonadotrophin dosage, expense, OHSS, and multiple pregnancies, emotional stress, and also the cancellation, with almost equal cumulative pregnancy rates. So we require optimal laboratory performance, individualized protocols, and associated with fewer complications and similar cumulative pregnancy rates. Now, looking at mild stimulation, one can use the benefit of oral ovulogens, either clomiphene or letrozole, and then add GnRH antagonists and gonadotrophins when the follicle size is about 14 millimeters. Or you can use letrozole and have a GnRH antagonist with gonadotrophins. Insufficient evidence to recommend mild stimulation in normal or hyper responders, but may be recommended in poor responders to decrease the burden of treatment. Moderate to high quality evidence on pregnancy outcomes in poor responders. So, will LH supplementation and who will it benefit? So, LH supplementation in previous indications like hypogonadotrophic hypogonadism, patients who are more than 35 years, profound LH suppression in GnRH agonist long protocols, low LH levels following GnRH antagonists, and the progesterone level of 1 to 1.5 on the day of HCG administration. And the recent add-ons would be moderate and severe poor ovarian reserves, hyper response to controlled ovarian stimulation despite normal ovarian response, and poor folliculogenesis and the hyper responders. So LH in poor and hypo responders. The Poseidon 1 and 2, you add LH. When you add LH, ratio from day 1, Poseidon 2, higher dosage, you add Poseidon 2, higher dosage, 300 FSH and 150 LH. Okay. And here in the triggering, it improves follicular output rate and follicular to oocyte index. And in Poseidon 3 and 4, stimulation up to FSH 300 international units, then add LH. Poseidon 4, duostim may help. Higher gonadotrophin dosages will never compensate for absence of follicles. Double trigger will improve the follicular output rate, follicle to oocyte index, significant increase of 30% in clinical pregnancy rates. So, LH pre-treatment in poor responders will show that the cancellation rate with pre-treatment is 22% as opposed to 51% previously, but the oocyte collected has been 3.5 versus 2.5 earlier. And the fertilization rate has not been different, but the cleavage rate has been 92% versus 62% in the earlier cycles. Transfer cycles, 54% in the LH pre-treatment when compared to 58%. And implantation rate was 22% versus 4%. Now, live birth rate was interesting, 29% versus 0. So it does say that pre-treatment with recombinant LH, 150 international units per day for 4 days preceding the administration of 400 international units of recombinant FSH in agonist down regulation protocol does help in giving better outcomes. So you'll see that in high responders, high purity HMG provided comparable efficacy to recombinant FSH with fewer adverse effects, including pregnancy loss, suggesting its optimized risk-benefit profile. So we now have the use of a long FSH, which can last for up to 7 days, and that is effective in stimulation of multifollicular growth and similar multifollicular development induced as daily injections. It's almost like giving 150 international units of FSH for 7 days. That is called polytrophin alpha. So there will be one injection given on day 1, and then there is a second, third, and fourth, there is no injection. Then fifth, sixth, and seventh, there is an injection. So effective in stimulation of multifollicular growth, similar multifollicular development induced as daily injections cannot be used for TI and IUI and not available in all countries, including India as of now, but is still in the post-marketing surveillance studies and should be shortly available. Next, double stimulation in poor responders and for the follicular phase, multiple waves of folliculogenesis within one cycle, therefore recovery of more oocytes in a shorter time, quality of oocytes in second stimulation as good as in the first with the same euploid embryo rate. So if we looked at it, mandatory freeze all needed, no RCTs comparing double stimulation versus the two conventional stimulations. The point here on the principle on what it works on is that we have multiple waves of folliculogenesis occurring in the ovary, in the luteal phase and the follicular phase. So the conventional protocol is to start in the luteal phase. The random start protocol can start in the late follicular phase or the luteal phase. And special consideration in hormone-sensitive cancers, you can use letrozole. And if you're working on double stimulation, you can actually have the first pickup around day 14, and the next pickup can come in after another 2 weeks. So therefore, in about a month, you can have 2 egg pickups. So the luteal phase stimulation will pick up the second wave of follicles and could be as much or even better than the first wave of follicles in the follicular phase. So if you look over here in a random start, you can actually start after getting the oocyte retrieval on day 11 or 12 of the cycle. You can actually start the aromatase inhibitor, letrozole, 13, 14, 15, 16, 17, 18. And of course, you can again start the stimulation and you can get your next cohort coming up perhaps in a 2 weeks' time. So with aromatase inhibitors, gonadotrophins, and antagonists, you are ready for the second oocyte retrieval. So you can have a agonist trigger, okay, and HCG as well, and the oocyte retrieval. Okay, next. So what is the algorithm based on 4 decision-making points? 1, individualize, depending on risk assessment and prediction of response by assessing AMH and AFC. Monitoring during ovulation induction, reduce the dose. In vitro maturation, antagonist posting, or cancellation of cycle. Trigger, avoid HCG. In vitro maturation, GnRH agonist trigger can be done. Then 4, OPU, cabergoline, and cryopreservation of all embryos. That's what could be done. Then a freeze in a segmentation protocol, to use a freeze all strategy is recommended to fully eliminate the risk of late OHSS, and prior to starting the ovulation stimulation, a risk assessment for high response is to be advised. Also, it is important to tell the patient if her tubes are open not to get pregnant in that cycle, because many times we forget to tell them that we do a freeze-all strategy and they go and have sex, and then we find that she comes back with a late OHSS. The other one is the use of recombinant HCG and urinary HCG is equally recommended for triggering final oocyte maturation during ovarian stimulation protocols. So, GnRH agonist trigger is recommended for final oocyte maturation in women at risk for OHSS, and it has a strong bearing. And freeze-all strategy is recommended to eliminate the risk of late OHSS and is applicable to both agonist and antagonist protocols. So, triggering final oocyte maturation with the gonadotropin releasing hormone agonist and freezing all suitable embryos could be considered in women with PCOS having an IVF-ICSI cycle with a GnRH antagonist protocol and at an increased risk for developing OHSS, or where fresh embryo transfer is not planned. So in IVF-ICSI cycles, in women with PCOS, consideration needs to be given to an elective freeze-all embryos. So dual trigger may be necessary in cases of suboptimal response to GnRH agonist trigger, could be as an incidence of about 5%, seen with lower FSH and LH levels on day 2 and low LH on the day of trigger and in patients with OCP treatment. GnRH trigger should be used only when LH is more than 0.5 on trigger day. So, dual or double trigger can be in the form of GnRH agonist and HCG administered concomitantly 35 to 37 hours prior to oocyte retrieval, and the combination of recombinant HCG of 250 micrograms or 650 international units of urinary HCG, that is around 5,000 international units, and 0.2 of triptorelin or leuprolide 1 milligram. So this is the combination that you need to use, and the double trigger would be GnRH 0.2 of triptorelin, leuprolide 1 milligram, and HCG recombinant is 250 international units or 6,500 international units of urinary HCG. It is administered roughly around 40 hours and 34 hours respectively prior to oocyte retrieval. So, GnRH agonist triggering mimics the natural cycle surge, aiming to significantly improve the outcome, oocyte maturity, fertilization rate, CPR, and live birth rate. Other studies did not demonstrate improved oocyte maturation, CPR, or OPR, clinical pregnancy and ongoing pregnancy. So good quality embryos in normal responder woman. So do we do indications for dual and double trigger? Dual trigger, diminished ovarian reserve, and poor responders, poor fertilization, abnormal follicular maturation, and poor oocyte maturity. Double trigger would be high proportion of immature follicle oocytes and low, less than 50% of FOD. Okay. So new gonadotropins on the market, corifalotropin. This we don't have yet, but because of the longer terminal half-life of 65 hours, we can actually give it at the time max of 25 to 45 hours. It's a good thing. It can last the entire thing can last for about 7 days, the FSH activity, and therefore in stimulation for multifollicular growth for IVF, but less suitable for induction in monofollicular growth and therefore for IUI. So if you look at corifalotropin alpha, it has a good follicular response, number of oocytes retrieved, fertilization rate, number and quality of embryos transfer, steroid production, follicular and oocyte gene expression and endometrial receptivity, clinical pregnancy rate and ongoing pregnancy rate, and live birth rate. So this is the neogonadotrophin's role of recombinant LH and ovulation induction. So LH deficiency, that is gonadotrophin deficient and ovulation, and patients treated with GnRH agonist, antagonist is something to see. Neogonadotrophins, that is polytrophin alpha and eutotrophin alpha, that is 2:1 ratio, and that is pergovirus. And this is used for low basal LH, suboptimal responders, young poor responders, and older women over 35 years. This has been showing very promising results, especially with poor responders. So here the FSH is in the ratio of 150 and LH as 75. So this is the same. It just shows you the groups of A and B. And what is important here is the total number of mature oocytes that have come in is significant in the groups that is in group A. And therefore, pergovirus has shown that in those groups which are poor responders, pergovirus has shown a distinct advantage. So in research, of course, a lot of things are happening. One needs to understand that the last word has not been written yet, and more work is going on in these areas. So a lot of receptors that are being identified, small molecules, LH receptors, FSH receptors, agonists, antagonists developed, some of which have shown highly promising efficacy in animal models. Small molecule agonists of LH receptors and FSH receptors have potential to become oral therapeutics for infertility treatment, whereas small molecule antagonists may find utility in oral contraception as well. So what has been the take-home message for all of you? Pre-treatment in an antagonist cycle may be beneficial for scheduling cycles and synchronizing of follicular development. Use of progestins for inhibition of LH surge is effective and safe, with good results reported in terms of the number and quality of oocytes, embryos obtained, and low risk of OHSS. Cost of progestin compared with GnRH analogs also seem extremely beneficial, and COS initiated in late follicular phase prevents premature LH surge and is an effective tool in combination with embryo cryopreservation in normal ovulatory women. Single dose of long-acting antagonist in luteal phase is effective in down-regulating and represents a new, possibly new protocol that will allow cycle programming and also totally eradicate hyperstimulation syndrome. And individualized protocols based on oral stimulation, increased safety and effectiveness through live birth rate is not different. Natural modified natural cycle and mild stimulation decreased the burden of treatment, especially in poor responders. Double stimulation in poor responders should only be used in the context of clinical research, but is a good option for fertility preservation. Random start protocols have a significant advantage by decreasing the total time for the IVF cycle without compromising oocyte yield, maturity, pregnancy rate for fertility preservation. So, adding letrozole to gonadotrophins effective and safe in estrogen-dependent cancer without compromising oocyte and embryo quality while minimizing the risk of high estrogen exposure. Dual double trigger improves outcomes in patients with history of poor fertilization, abnormal follicular maturation, and poor oocyte maturation. OHSS can be prevented by risk assessment with optimization of stimulation and use of segmentation protocol. However, further studies are needed, especially on reproductive, obstetric, and long-term neonatal outcomes before these protocols can be introduced on a wider scale. So thank you all very much, and I am prepared to take your questions.
Thank you so much, ma'am, for your wonderful presentation. We have some questions from our audience if you'd like to take that up.
Yeah, go ahead.
Thank you, ma'am. So, ma'am, the first question from our audience is, what ethical and legal consideration should be taken into account when offering ovulation induction in art?
I think when you are talking about ethical and legal consideration, um, can I see the audience or I don't see any audience here?
No, ma'am, you can't
No.
see the audience now.
Okay. The ethical considerations would it's the consenting. That's what we need to do. As long as the patient understands that when you're giving any drug, you have to take the consent that the side effects of the drug has to be explained to the patient, that with this drug there could be some side effects, whichever drug it is. For example, if it is clomiphene citrate, the drug could have its effect on blurring of vision, it could have blackouts, it could have nausea, vomiting, and of course the drug could lead to hyperstimulation. So even drugs like clomiphene citrate can lead to hyperstimulation, and so also the gonadotrophins. So unless you explain that these drugs could lead to multiple ovulations or multiple follicle development, and therefore we may have to abandon the cycle, or you may have to have the follicles aspirated. So you may have to go to a higher center to get that treated. These are things that will have to be put down in the consent form, and that the person will have to understand that that is a small risk, however small, but it is a risk that has to be understood. So once they understand that, that will be legally covered, and the patient has to be clear that there could be an extra cost involved, which has not been figured out in what they have been given, because side effects cannot be figured in the cost of the treatment. So if this has been told to them, then I think you're fairly safe. Now, from a legal perspective, I think the indication for ovulation induction is for the sake of the baby. So if you tell them that you may not get pregnant, so just by doing ovulation induction, it does not guarantee a pregnancy. So question is that ovulation induction is to only see that the follicles rupture. You are not promising the baby in the hand. So many times when you do ovulation induction, there is no 100% guarantee that the baby, that the success is, 100%. So when you over promise and under deliver, this is where that misunderstanding occurs between patient and doctor. So you have to be absolutely clear with them that all you're doing is you're actually creating ovulation, but thereafter there are a lot of processes after that for the pregnancy. For example, that the tubes have to be opened and the sperm has to be okay, there should be no infection, and of course the chances of normal pregnancies is around 30%. So there is a chance you may not get pregnant. And if you do get pregnant, then the chances of that would be much better. If the follicles grow well, endometrium is fine. So you have to be very realistic when you counsel them. So if you have not counseled them and you say you're going to get 100% pregnancy, that's where the legal problem will come in. So as long as your consenting form explains everything and you're sure that you're given the side effects and also the chances of pregnancy, then you're safe.
And thank you so much, ma'am, for answering this question. The next question from our audience is, what are the challenges and opportunities in counseling patients about the potential multiple pregnancy risk associated with ovulation induction?
I think if in this day and age, if you are able to manage, or well, you can't prevent multiple pregnancy, you can decrease the chances of multiple pregnancy by taking precautions. One is when you induce the patient in terms of ovulation, if you find multiple follicles, the best thing is to cancel that cycle. Or if you find multiple follicles and you're able to sort of aspirate the follicles and you can actually freeze those follicles for her, then you don't have to cancel that cycle. But you tell her that if you are going through an aspiration and you've left only one or two follicles, you can't be sure that even if she tries naturally, there could be a chance that she could get pregnant with twins. Many times people would be ignorant and they say that, okay, it's all right if I have twins. In that case, then it's okay. But then, if they say at whatever cost, I don't want to have twins, then it is best for them to avoid intercourse in that cycle and let them have a period. Because the only thing that you should do is abstinence, and make sure that you don't do anything beyond that particular thing, and let them go through that cycle without going in through any kind of timed intercourse or IUI in that cycle. And make sure that if there is multiple follicles developed, either you burn them down by giving progesterones, or you aspirate them and freeze those oocytes and don't use that cycle at all. These are some of the precautionary measures that you can do. But at the same time, after doing that, please tell them not to have intercourse. They would say, okay, 2 days I didn't have, then the third day I'll have. For that cycle, please do not have. Then, after you've had a period, then you can start again. Because these are some of the precautionary measures you have to take. And if you don't get a period in 2 weeks' time, then please report to the doctor with a pregnancy test, because it has to be clear whether you have a pregnancy positive, and also whether the pregnancy is in the uterus or not, or is it a heterotopic pregnancy, which is a pregnancy in the tube and in the uterus. So you have to be very clear right in the beginning.
Thank you so much, ma'am. The last question from our audience is, what are the potential risk and complication associated with ovulation induction in art, and how can this be minimized or managed?
Yeah, I think in my slides, I have already given this entire thing about complications in art, because one is art has to be done by qualified people. It cannot be done by a routine gynecologist. As the art law has come in, they have said that you have to have a fellowship plus 3 years of training in art, purely because it's a multidisciplinary approach. There's a lot of endocrinology involved, and because there are important factors where the patient's issues have to be taken into consideration. Because one, the psychology of the patient, the endocrinology, then there is male factors involved, plus there is also the stimulation protocols. And the difficulties here would be if things go wrong. One, where you have hyperstimulation syndrome, you've got to manage it very well. Otherwise, the fluid electrolyte balance, if that is not looked at, then the person may land up with a lot of fluid in the belly, and this could lead to a lot of electrolyte balance, and we may have to manage her in the ICU. So now, of course, the OHS free clinic is there because of the very careful monitoring of the patient. So we don't see such patients now. But the other thing would be in these cases is to make sure that we have different kinds of stimulations now. So to understand the patient and the way you stimulate the patient and the way you manage patients with all the comorbidities needs a lot of experience, and this is a subspecialty in its own right. So once you have had that kind of an experience, you will be able to manage more and more difficult cases. So anything that you have, for example, if you've had diabetes, or you've got hypertension, or you've got endocrine disorders, thyroid, and of course other immunological problems along with infertility, then you have to take the comorbidities along, and you have to treat the person as a whole. You can't treat an organ, you can't treat a uterus, or you can't treat an ovary. So therefore, it becomes a specialty in its own. So trying to treat infertility and make it light, it doesn't work. So therefore, keeping all of them together, and my slide also shows the difficulties that you have while treating the patient, and the number of stimulations that I have given will itself tell you that how difficult it can be. That in spite of all this, it's not about individualizing treatment, but personalized medicine is what we should be doing for the patient, because every patient doesn't come with something stuck on the forehead that you have to have a long treatment cycle or a short treatment cycle. But with all the comorbidities in, you have to be careful, and you have to be all the time careful that you do not do any harm to the patient.
Thank you so much, ma'am, for answering all our questions. Before concluding today's session, ma'am, any last remarks from you?
Pardon?
Ma'am, I was saying any last concluding remarks from you, ma'am, if we can get. It will be really great.
Well, I think I would like people to read. I'd like people to get into infertility, because with the growing population of infertile couples, I think more and more people need to study the subject in detail, and not to just practice it very lightly, because we do not have enough infertility specialists, and the kind of ratios we have of people doing infertility practice and the qualified ones, there is a wide gap. And I wish that all of them can do it. We ourselves do an online program, because we don't have time for a lot of the doctors who want to earn and learn the online programs in infertility practice, so that they learn the subject well and they're able to practice the subject well. And I have found a lot of people really benefiting from this online program in Medline Academics, purely because they can't spend one full year doing fellowship after really being busy in their practices. But whatever it is, I think all the doctors need to study infertility before they just get out and start treating patients of infertility, because it's a very complex subject. But I wish all doctors all the best. Please treat all infertility patients with empathy, and make sure, because they have been really ostracized in society. I don't want them to be ostracized anymore. Thank you.
Thank you so much, ma'am. Thank you so much joining us today. With your permission,